Myopia in children might be grabbing all the headlines, but adults are also in the disease's crosshairs. Myopia can have a drastic effect on an adult's vision and quality of life too. So what to do? In a recent Cake magazine supplement, a consensus group of 11 world-renowned experts came together to frame the discussion on the current myopia correction landscape, including phakic IOLs. In measurement matters, the panel was conspicuously split. Consensus voting on phakic IOL sizing decisions spread recommendations between many primary measurements, including white-to-white, OCT, and UBM.
Part of the reason that there's all these different ways of measuring is that the lens doesn't always exactly sit in the same place. And Roger Zaldivar has really good data where he shows that sometimes both ends are in the sulcus, sometimes one is in the sulcus, one behind the ciliary body, sometimes they're both tucked behind the ciliary body. And so you can have all this variability of the actual position of the lens, which can lead to a variable vault. And so since we can't actually see where it's going unless we're doing, UBM and things like that after, it's hard to know if the problem is in the measurement and the input or actually where the lens is going. For me, how I like to size patients is I use a digital caliper to measure the white-to-white because I think that's the closest thing to an orb scan and a true white-to-white measurement. And I also am a strong believer in using UBM. I really like to evaluate what the angle configuration is, what the lens rise is, the iris configuration. All of those things are a little bit more of a gestalt. And when you do a lot of these, you just kind of start seeing different anatomies. Some angles look more crowded. And so maybe if you're between sizes, then I'm going to size down.
White-to-white is a good measurement, but with time, we understand that there are better methodologies and that we can add value on that, having those numbers. And angle to angle has shown a better correlation with the internal structures. Basically, the ICL stands in a ciliary body position in almost 81% of the time. And the correlation with the ciliary body and the sulcus to sulcus is 0.6. But the correlation between that and the white-to-white is 0.2. It lacks completely of correlation. Today we have truly embraced UBM as our standard method, because we have found consistent better results comparing this with OCT, even the newest formulas, and with white-to-white. So if you're going to do something very important for an elective procedure, I think that you have to try to do it the best way.
So there's a lot of methods and ways to obtain a measurement to size your ICL. In the United States, we try to stick to the DFU, or the directions for use, and with that, it's measured based off of white-to-white for the most part. So that's your orb scan 2 in the original DFU and caliper measurements. Now, many people don't have an orb scan 2. We have modern biometers. And with that, we have to have an adjustment factor because they don't all measure the same. My IO Master 700, Argos, all of these things, all of the biometers measure a little differently than the OrbScan 2 did. And with that, it's important to adjust back to where the OrbScan 2 would have measured. And with that, for the most part, we see that the ICLs would be sized down a little bit, especially on the border ranges of the different sizes. The rate of ICL explant or exchange due to sizing, especially amongst high volume users, is exceedingly low. Personally, I have not removed a single ICL due to vault size ever.
The gap between the ICL and crystalline lens is a unique and critical feature of phakic IOL implantation. According to the panel, a mean vault range of 213 to 885 microns was considered best following ICL implant.
It's important that it's considered as vault range, right? There's not one ideal vault. Every patient's eye is just a little different. And while we do have 4 sizes of ICLs, the vault size will be different and it will vary, and that is okay. It's okay to have a vault at the lower end of the spectrum. It's okay to have a vault at the higher end of the spectrum, so long as the angle is open, the pressure's good, and the patient's seeing well. So I think it's important to think of this as a range, and I think that's a very accurate range to consider and be comfortable with an ICL landing.
I totally agree with it. I think that's absolutely perfect. Even a low vault below that is not necessarily a reason to remove the ICL. With EVO, we have a lot more confidence that the risk of ASE is extremely low. It's safe to observe those patients and monitor for any cataract. And then on the high vault side, That makes surgeons a little bit more nervous, and so generally I try to size down if I'm between sizes to avoid the high vaults. A high vault in and of itself is not a reason to exchange. A high vault is only a reason to panic or exchange if you have narrowing of the angle or high pressures. But the number value itself is maybe less important than what's actually happening in that patient's eye.
So a lot of that can be a holdover from the legacy ICL. There we had significant concerns about vaulting, especially a shallow vault that we knew would cause a cataract. The rate of cataract with EVO is relatively non-existent, and we think that's because there's almost a fluid cushion provided by the lens and the aqueous that's coming through the central pore. With the cataract rates being so low, we're really not as worried about the angle closing because many of these are deep eyes, long eyes anyways. Maintaining a good vault size is obviously important. It maintains the longevity of the procedure and gives us confidence as surgeons that the patient's going to do well.
If you have an overvault and you have an eye that is not big enough or is a standard eye, you might finish with a small angle. On the opposite, you have a huge eye and you finish with very low vault, you'll be uncomfortable because you don't know if it's enough to avoid circulation or not, or it may develop cataract. So there are standards that have been understood in many, many years of follow-up that, at least for me, is you want to have 200 microns in certain power, because then we have deeper conversation that each ICL has different powers. The higher the power of the ICL, the thicker the meniscus in the periphery, so you need more volt. It's very tailor-made procedure.
This video is just one part of our series looking at the guidelines on building proficiency in phakic IOL procedures. Scan the QR code below to access the entire supplement and learn about common practices from some of the world's best phakic IOL surgeons.